Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is about in-hospital management of hyperglycemia. We are pleased to have Dr. Jayashree Gopal as the moderator for this session.
Hi, Ravikiran.
Hello.
Hi,
Yeah,
Ravikiran,
we can
welcome.
hear you.
Welcome.
You can tilt your computer screen a little bit down so that little bit so you can see. Right, fine. Fantastic. Yeah, Vidya.
We are pleased to have Dr. Jayashree Gopal to moderate this session. Dr. Jayashree is the director of Endo India, Chennai Institute for Diabetes, Endocrine, Metabolic and Lifestyle Health, and a senior consultant endocrinologist and diabetologist at Apollo Hospitals, Chennai. Dr. Jayashree did her MBBS from Madras Medical College. She trained in diabetes and endocrinology in the United Kingdom and United States and is a diplomate of the American Board in Internal Medicine, Endocrinology and Diabetes. She is the Vice President of the Endocrine Society of Tamil Nadu and Pondicherry and also the founder trustee of Endo India Foundation, which works towards preserving health across generations. Thank you, Jayashree, for immediately accepting our invitation. Over to you to introduce the speaker and give a brief outline of what we plan to do today.
Yeah. So it's a pleasure, Dr. Vidya, and I have been following you and attending some of it live, but watching a lot more on the YouTube. And again, congratulations. It's really a pleasure to be here to moderate a session at which Dr. Ravikiran is talking. And I'll introduce Dr. Ravikiran in a minute, but he's going to be talking about a topic which is becoming, sadly, more and more common. We are seeing an increasing number of diagnoses of diabetes, particularly among the younger age group in the population, and a significant percentage of people who get hospitalized tend to have high blood sugars, whether or not they've had pre-existing diabetes. So studies have shown that up to 50% of hospitalized patients in some studies, and in our country it will be far more. I think all of you would agree it would be like 50 to 70% of all hospitalized patients have high sugars. And how we manage with it becomes a challenge because quite often these people are not eating at regular intervals, they're vomiting, they're going for various tests, or they have surgeries or other medications. So it really is a challenge to manage. It is truly an art. I think in-hospital management of diabetes is truly an art. And I'm looking forward to hearing what Ravikiran has to say. And it gives me great pleasure to introduce Dr. Ravikiran, who is currently a consultant endocrinologist at the SIMS Hospital in Vadaparani, and he's also has his clinic at the Diaplus Endocrine Center. He graduated from Tanjavur Medical College and subsequently went on to do his MD Internal Medicine and DM Endocrinology from PGI Chandigarh. And he's won many accolades and awards throughout his academic career. We have a very prestigious award for PGs called the A.V. Gandhi Award, and that is won every year by the person who's considered the best postgraduate, and he won that actually in 2010 for his work in a community-oriented research study. And of course, he's a very familiar face to all of us in the endocrine circles. I just wanted to touch upon a couple of the projects that he worked on, one of which was the prevalence of metabolic syndrome and obesity among adults in Chandigarh, and another one was the prevalence of goiter and its association with various micronutrients like iodine in Chandigarh. So Ravikiran, it's a pleasure to be here outside our usual sort of platforms. I'm looking forward to hearing what you have to say. Over to you.
Thank you, madam. So thanks for the kind introduction. I will be sharing the slides now. Hope you are able to see the slide.
Yeah, we can see it, and it's full screen. Yeah.
So, okay, I'm proceeding. So we are all aware of potential harms of uncontrolled blood glucose levels, infection, delayed recovery, longer hospitalization, and eventually which may culminate in higher mortality. Generally, what we do on day of admission, we check HbA1c, renal and liver function, and we look for any past history of hypoglycemia. Many patients don't enter the usual way, but rather present in a sick manner and end up in ICU. So I think it is pertinent to start with glucose control in ICU, then cascade down to ward and then other settings. So the ICU sugar control has long been a matter of debate. The benefit has never been questioned, but what are the cutoffs for the appropriate glucose level, and at what level the benefits become less and the harmful effects become more? That is a matter of debate. So this is one of the early studies which showed that when the mean blood glucose levels in medical surgical ICU is kept at different levels, they studied the hospital mortality rate. And one group had a mean glucose level of 152 shown by bar in green, and another group had a mean glucose level of 130 shown in yellow bar. Clearly, we can see that there is a reduction in mortality at the end of the hospital stay. This is a study comprising 1,600 subjects. So after that, particular attention was focused on CABG, especially in diabetics. In this particular study, they found that around 2,000 patients, they found that as the blood glucose level rises, mortality also rises. And if the first post-op glucose is more than 200, if uncontrolled patient is taken up for an elective procedure, major elective procedure, the stay is extended by 2 times, ventilator duration increases by 3 times, and mortality may go up by 7 times. This was one of the early studies published by Fimari 25 years ago. This triggered subsequent studies, especially the notable one is the one Leuven SICU, surgical ICU study done in Nordic countries. Around 1,500 patients admitted to surgical ICU receiving mechanical ventilation. There are 2 types of insulin therapies. One was labeled as conventional therapy. The target blood glucose level was 180 to 200. However, they managed to achieve a mean blood glucose of 153. Another group which received intensive therapy, the target was 80 to 110, and the mean blood glucose reached was 103. So essentially, even though the target itself was a little different, the achieved mean glucose was 153 versus 103, around 50 milligram per deciliter difference between the groups. So the Apache score was 9 on the whole. And in the conventional therapy, until the glucose crossed 215, they did not resort to continuous IV insulin. At the end of the trial period, they published the study. 2 results are notable. One is the survival in ICU itself, and another is the in-hospital post-ICU survival. In both the groups, you can see the post-surgical patients who received intensive treatment, they did better. Survival was better, almost by 40% as compared to conventional insulin group. And in-hospital survival was better by around 30% in intensive insulin group as compared to conventional treatment group. So the Leuven surgical ICU trial is a big success for big propaganda for intensive insulin therapy in ICU, targeting a blood glucose level less than 110, a very stringent level to achieve and maintain without hypoglycemia. Several years after that, NICE sugar study came, published in 2009. This is a much bigger study, around 6,000 patients, 3,000 randomized to 2 groups. One group received intensive insulin similar to Leuven ICU, surgical ICU. The sugar was attempted to be maintained between 80 to 108. Another group had a conventional glucose control of less than 180. They found that all-cause mortality was contradictorily, it was worse in intensive glucose group, and even severe hypoglycemia was more. So contribution of severe hypoglycemia partly to mortality also was discussed. So we can see hypoglycemia was more in intensive group. Here, the difference between the 2 glycemic control groups was not very different. The average glucose achieved in intensive group was 118, and in conventional group is 145. The difference is only 30 milligram per deciliter between the 2 groups. However, the results are markedly different. Hypoglycemia is much more common, around 10 times, 12 times more common in intensive group. 28-day mortality and 90-day mortality, both were worse in intensive glucose control group. So at that point of time, people started weaning away from intensive control and started adopting a more relaxed control. There are several reasons attributed for the change in results between nice sugar and LUVAN. If we look at the target, that itself will probably give us a clue for part of the results. The yellow line represents the nice sugar, and the LUVAN surgical ICU trial is represented in the blue line. Between the intervention group and the control group in LUVAN trial, almost 50 milligram per deciliter gap was there. One was clearly in normal range, another was clearly in abnormal range. But in the nice sugar study, the two groups have come closer together. Even the control group was very much in the normal control range. So the part of the benefits might have got obliterated because the control group also was very much in the normal glucose range. Apart from this, several other trials have been done. Vanderberg herself did one other medical ICU trial and published in 2006, listed second in this slide. The benefit was much lesser. There was an overlap onto either side of neutrality, odds ratio. In several other trials, especially those done in medical ICU, showed worse outcome with very stringent glycemic control. So after 2009, the idea of intensive glycemic control, especially targeting a glucose below 120 and 110, that has been dropped. Now people are going for moderate control in ICU. By moderate control, the numbers will be 140 to 180 milligram per deciliter. So that is the story for ICU glucose control. So the similar thing has been done in so many other trials in different sort of ICUs. Mixed ICUs having both medical as well as surgical patient, surgical ICUs, exclusively medical ICUs. So one point to note is in surgical ICU, still a lot of studies showed better results favoring stringent control, especially the post-cardiac ICU. So that has to be kept in mind. The medical ICU by default might be admitting very sick patients from beginning. The surgical ICU might be admitting more stable, simpler to manage post-op patients. So that also may be altering the results. If it is a mixed ICU, better to go for a relaxed control, medium level of control, 140 to 180. In specific situations, maybe in post-cardiac ICU, for a post-cardiac surgery ICU, maybe a slightly more stringent control between 110 and 140 may be adopted by some units. So there are several reasons given why this contrasting result came. We will not go into it here. The most important point is medically sick patients may be sick to begin with, unlike a stable elective post-elective surgery patient. So that may be the most important reason why medical ICU patients perform worse. So then that raises the question whether hypoglycemia itself, whether it is just a consequence of intensive insulin control or it was a marker for a pre-existing disease. For example, in post-acute myocardial infarction, there was a U-shaped relationship between blood glucose and mortality. Both at the lower end and the higher end, the mortality was higher. The sweet zone was somewhere in between 81 and 125 or 81 and 149. The other categories of blood sugar control showed worse result. So they did several subgroup analyses exploring this concept. Again, whether it is non-postoperative or postoperative, hypoglycemia definitely showed a worse outcome irrespective of the setting. So whether hypoglycemia is a marker or a mediator, one clue comes from the fact that spontaneous hypoglycemia in non-insulin treated ICU patients, it is associated with worse outcome than hypoglycemia after insulin. So possibly that indicates that the pre-existing medical disease itself may be pushing patients into flagrant sepsis and hypoglycemia. So that may confound our reading the situation, including the patients who are on insulin. So it looks like the patients who are admitted into medical ICU with the pre-existing disease, in them hypoglycemia is more a marker of pre-existing disease rather than mediated by insulin itself. So what are the glycemic goals? After so many studies and so much analysis, what are the in-hospital glycemic goals adopted widely now? If it is a critical illness patient, given at the bottom of the slide, ideally the random glucose should be kept between 140 and 180. Post cardiac surgery, certain units may prefer to have lower sugar control, but not a widely adopted standard. Non-critical illness, if the patient is eating, the pre-meal blood glucose level should be kept below 140, and random blood glucose level ideally should be kept below 180. And if the blood glucose level crosses 100, then we should modify the treatment regimen, make it simpler and more relaxed. So broadly, these are the two options for managing hospitalized persons with diabetes. We can choose continuous variable rate IV insulin drip in those who are undergoing major surgery, who are to be kept nil per oral, who are having unstable hemodynamics, those recovering from MI, those who presented with DKA or severe hyperglycemia, those who are planned to be put on steroids like acute COPD or some other condition, those who have gastroparesis precluding enteral or oral intake. So there are several conditions where IV insulin drip is the best choice. When the patient gets shifted from ICU to ward and when they start eating, basal plus bolus therapy could be implemented. This in broad is the summary of what insulin we choose and what regimen we choose. We will go into slightly more detail in the ensuing few slides. So in critical care, IV regular insulin infusion is the standard of care. The target we already discussed, 140 to 180 is the ideal target for glucose. Glucose monitoring should ideally be done 1 to 2 hourly and the rate should be modified accordingly. There are several algorithms for modifying the rate in critical care. Before going to it, just a short snap of what are the types of insulin available today. We can see the rapid insulin given in maroon, dark maroon, and the short-acting regular insulin presented in orange, intermediate NPH insulin presented in green, long-acting detamir and glargine given in blue and red. So these are the different types of insulin, each with differing duration of action. For example, detamir and glargine are very long-acting, anywhere from 18 to 24 hours. So they provide basal cover. The first two sort of insulins, rapid and short-acting, are meant to be given along with meal. They offer glucose control only for 4 to 6 hours. So this has to be kept in mind while choosing the insulin. There are various IV insulin protocols. Including these have been validated in trials, Atlanta multiplier, Vanderburg's, the Nordic trials, Portland protocol, Yale protocol, Markowitz. These have been studied in different settings, some in surgical, some in post-cardiac, some in medical. It's up to the particular ICU to choose one and adopt. For example, if we look at multiplier method, closed loop insulin delivery, what happens, every year the nurse has to check sugar level. The insulin rate is modified as per a formula. We have to multiply the current glucose level. We have to subtract the glucose level by 60. Whatever value we get, we have to multiply by 0.02 and add to the insulin rate. So it's quite complicated to be implemented without a dedicated nurse. So every year the rate will be different according to the 1 hourly glucose level and the formula result. So this is one such example. Starting rate will be units per hour. Blood glucose minus 60 multiplied by 0.02. BG is current blood glucose and 0.02 is the multiplier. So every hour we have to check glucose and adjust the drip. Not easy at all. So, but what is a simple method of determining initial insulin dose? There are 3 different insulin doses we can consider. Somebody with a normal weight, the total insulin dose could be 0.4 units per kilogram. Somebody who is underweight or older age or hemodialysis could be, we can choose 0.3 unit per kilogram total daily dose. And somebody who is overweight, we can choose 0.5 units per kilogram total dose. So this is the initial dose. Subsequently, according to the hourly or 2 hourly glucose level, we can modify the insulin rate. Again, touching upon the different types of insulin, this becomes crucial in managing glucose level in post-op ward. So after shifting from ICU, we have to consider appropriate transitioning from intravenous insulin to subcutaneous insulin. Whatever the intravenous insulin rate in the last 4 hours or last 6 hours or last 8 hours can be taken. If it is 6 hours insulin rate, if it is stable, we can multiply by 4 to arrive at 24 hours insulin requirement. If it represents the last 8 hours insulin dose, we can multiply by 3 to arrive at 24 hours insulin requirement. So can we add any other medication, or if we should strictly stick to insulin? Once we shift toward and patient starts taking orally, the options widen. Insulin is still the foundation. There are few regimens like basal bolus, where we give 1 injection of basal insulin and 3 injections of bolus insulin along with meal, pre-meal we give. Or we can opt for a simpler regimen in elderly persons like called basal plus, where we give 1 injection of basal and 1 injection of bolus insulin. Or we can go for the premix insulin, where 2 types of insulin are already manufactured together. It comes in a fixed ratio like 30-70 or 50-50. We can choose to give it twice a day for patients taking meals orally. At this stage, we can also consider adding sitagliptin or liragliptin because they are quite safe. They are compatible in most situations except in extreme liver failure or extreme renal failure. Even low dose glycoside modified release has been used and safe to add at this stage. What are the drugs to avoid in hospital, either in the post-op ward or after shifting from ICU? Pioglitazone should not be used because it leads to fluid overload and can precipitate cardiac failure. SGLT inhibitors may cause dehydration, may worsen renal oligemia, may increase the azotemia, so should not be used, and may even predispose the patient to ketosis and ketoacidosis. Acarbose and oglibose increase bloating and cause discomfort. GLP-1 analogs of late have been tried, but again, could be cumbersome for average patient taking 1 or 2 injections extra in addition to insulin. Sulfonylureas and metformin may be added just before discharge, but not while patient is recuperating from the surgery. So there was one trial which was done in this group of patients, RABBIT-2 trial, where basal bolus insulin regimen was compared with sliding scale insulin. Just a word about sliding scale insulin. Sliding scale just means correctional insulin. The sister will look at the sugar level. For example, if it is more than 240, the doctor would have instructed to give 4 units of insulin. She will give 4 units of insulin. Again, after 6 hours, the sister will look at the sugar level. If it is 210, the doctor might have ordered her to give 3 units of insulin. She will give 3 units of insulin. So we allow the sugar level to escalate. Then as after reaction, we give a certain units of short-acting insulin. So this happens 4 times a day. So we are not proactively managing with the sliding scale, but rather we allow glucose to slip away to a higher level, then we react. So this is the convent. This was used in 80s and 90s. Nowadays it is discouraged. What we should do is, ideally we should calculate the total daily requirement and institute a certain amount of total daily requirement as a basal insulin. On top of basal insulin, we can give correction in insulin or a pre-meal bolus. So RABBIT-2 trial employed this concept. The trial was between basal bolus and sliding scale insulin. The subgroup of patients who are on sliding scale insulin at admission, they were switched over to basal bolus after 3 to 4 days. The blood glucose drastically improved towards the normal zone. And the 2 set of patients who were originally assigned to sliding scale and basal bolus, they were also followed up to discharge time. After 3-4 days, the basal bolus insulin group performed markedly better, and this benefit remained till the discharge time. So RABBIT-2 trial is a very well-known trial which emphasizes this concept that we should add a basal insulin. On top of it, we can add either pre-meal bolus insulin or a correctional insulin. The basal insulin is crucial. So the patients could be in different states of nutrition. What are the different insulin strategies we can adapt? Suppose the patient is not taking anything by mouth, is on clear liquid only. If the sugar level is more than 180, whatever is the total daily dose calculated as per the weight, we can consider giving 25% of the total daily dose as a basal insulin. Suppose the weight is around 70 kilogram. If the insulin dosage we want to go according to 0.4 units per kilogram for the whole day, then approximately around 30 units will be the total daily dose. 1/4 of the dose, around 8 units, we can give as the basal insulin in this case. So that is the initial dose, we can subsequently modify. If on this basal insulin, the sugar still slips away beyond 180, we are free to add supplemental insulin after doing checking sugar level 6th hourly. So there are several other ways of giving nutrition. Bolus tube feeding. The suggested basal insulin dose is around 40% of total daily dose. And the remaining 60% can be distributed in 4 divisions given across the day, 6th hourly. A similar pattern for continuous tube feeding. 40% of calculated total daily dose can be given as basal insulin, and the remaining 60% can be divided into 4 equal doses and given 6th hourly to cover the whole 24 hours. Suppose the patient starts eating, then we can modify the dose slightly. 50% can be reserved for basal insulin, and around 50% can be distributed for the 3 meals of the day. So these are all arbitrary, somewhat arbitrary. This is only the initial dosage. Need not be followed every day of the stay. After the first day of stay, we will know what is the sugar response to the initial insulin strategy. On the second day, based on the glycemic response, we can modify. Just to highlight how it is done, the gray shadow indicates how the sugar goes up after a meal. We can imagine patient taking insulin 3 times a day, food 3 times a day. Here the timings are denoted as 8 o'clock, 12 o'clock, and evening 7 o'clock. And the short-acting or rapid-acting insulin is given, highlighted in red here. Aspart, Lispro, or Glulysin can be given 3 times a day. And the 4th red arrow represents the long-acting insulin, basal insulin, chosen to be given at 10 p.m. after the patient finishes the dinner. So this is a very common pattern of insulin administration we employ in post-op patients or patients who are recovering from some illness. So 3 pre-meal short-acting or rapid-acting insulin plus 1 long-acting basal insulin analog at night. Suppose the patient is on different type of regimes, nutritional regimes. There are again different types of insulin regimes employed by different researchers. They have published also. Some people prefer to give NPH and regular insulin in a certain ratio. There are few studies even with NPH alone given 3 times a day with somewhat okay results. But what we discussed so far is the most common basal bolus regime, 1 long-acting and 3 or 4 short-acting insulins per day. One word about peri-procedural management. Suppose the person arrives for a procedure, could be a procedure lasting more than 2 hours, could be a procedure lasting only half an hour. On the day of surgery, the first graph shows that short-acting insulin can be omitted, Aspart or Glulysin or Lispro. On the evening of surgery, we can resume, if the patient is allowed oral intake, we can resume short-acting insulin, and the Glargine can be given for the night for the peri-procedural glycemic management. Suppose if you are giving a combination of NPH insulin, which works for around 12 hours, and regular insulin, which works for around 6 hours, on the morning of procedure, we should omit the regular insulin highlighted in green. We can consider half a dose of NPH on the morning of procedure just to cover perioperative stress-related hyperglycemia. And evening, if food intake is allowed, we can resume the regular insulin plus NPH. So this is one way of going about the insulin regime. There is no fixed criteria that this is the only way it should be done. Different physicians may use their judgment and titrate differently. So there is another way of going about the correctional insulin. The doctor can attach a pre-ready insulin correctional scale. Suppose a patient, for an average patient, the moderate dose can be used. If sugar level is between 140 and 180, the nursing staff is supposed to look at the sticker and give 2 units of insulin extra. In this, there are 3 columns are given: low dose, moderate dose, and high dose. The purpose is some people may be very lean, they may require less insulin, they may be more insulin sensitive, or they may be having concomitant medical disorders like liver dysfunction or renal dysfunction. Overall, they may be more prone to hypoglycemia if more than a certain amount of insulin is given. For them, the low dose scale can be chosen. Another group of patients will be obese or receiving steroid or recovering from sepsis. Still, there will be a certain amount of insulin resistance. For them, high dose correction insulin scale can be chosen. So these are all variations in how the supplemental dose is chosen. A small word about the correction bolus formula, just not to complicate it. I will keep it to just half a minute, just 10 seconds. Suppose at a certain point of time, suppose at 12 o'clock we check sugar, the glucose level is 250. The ideal glucose we want to reach is towards 100, around 140, 100 to 140 or 140 to 180. There is a thing called glucose correction factor, 30 milligram per deciliter. We can subtract the current blood glucose using the ideal blood glucose. So we can arrive at the average sort of insulin to be given at that point of time. So the correctional insulin to be given for that particular time will be 5 units. Like that, every 6 hours we can check sugar, and whatever extra insulin is needed, we can add. This is one way of going about it. The other way, simpler way we saw earlier, already a sticker is, a poster is stuck to the nursing board where they can choose insulin dose looking at the ambient glucose level and what sort of patient we are dealing with, whether he is an average patient without any comorbidity, a sick patient who is more likely to go into hypoglycemia, or a very obese patient or steroid receiving patient who requires more insulin. So there are 2-3 ways of going about the correctional insulin. A word about ambulatory surgery. So far, only one well-known organization has given any sort of guideline for ambulatory surgery. For ambulatory surgery, IV insulin is not recommended. Even more than regular insulin, SAMBA is recommending subcutaneous rapid-acting insulin analog. The treatment goal is similar to other settings. Intraoperative blood glucose level should be attempted to be kept below 180. So that is the recommendation by SAMBA. So just to summarize what we discussed so far, suppose if the patient is having mild hyperglycemia, if the patient was taking less than 2 antidiabetic agents or was insulin naive, we can choose a DP4 inhibitor, a oral drug, or we can give oral drug plus small correctional doses of insulin whenever the sugar slips out of that 180 to 100 range. The second category of patients will be those who arrive with slightly worse hyperglycemia, blood glucose falling somewhere between 200 to 300, taking multiple oral antidiabetic agents. There, arbitrarily, we can choose an insulin total dose of 0.6 units per kilogram per day. That can be divided into 2 portions. One portion is basal insulin. Another portion is for either pre-meal bolus or correctional bolus. The third category is those who arrive with severe hyperglycemia, blood glucose more than 300. Most probably they will be on multiple antidiabetic agents. There, the arbitrary total insulin dose could be calculated as 0.6 units per kilogram per day. From that point, we can divide the insulin, apportion the insulin into 2 groups, half for basal and half for short-acting or analogs, rapid-acting analogs. So this is one way of going about insulin regime in different categories of patients with different categories of hyperglycemia. So at discharge, we have to think about the HbA1c, age of patient, organ dysfunction, whether the patients will be able to follow a complex insulin regime like 1 basal plus 3 short-acting insulin, and what is the estimated risk of hypoglycemia. All these factors should be kept in mind and a prescription issued. A word about point-of-care devices and glucometer accuracy. In all this discussion, mostly we'll be using point of care devices, glucometer, with once a day or twice a day counter check by the lab glucose. That's the usual paradigm nowadays. Glucometers are by no means accurate. They are prone to errors, either because of the chemical method they use or because of the generation they belong to. The general recommendation is that the accuracy should be within 12 milligram per deciliter of the lab glucose. And another standard is telling it should be within 15 milligram per deciliter of the lab glucose. So there are two standards internationally. And a simple thing like hematocrit can alter the glucometer performance. Anemia patients may show slightly high values, and polycythemia patients may show falsely low values with certain glucometers using certain chemical methods. And there are also continuous glucose monitoring devices. The commonly available one records interstitial glucose every 5 minutes. It comes as a patch which remains applied for 14 days. It is acceptable for hemodynamically stable patients, but it has to be counter-checked daily with lab glucose. So thank you all for patient listening. Over to Dr. Jayashree.
Thank you very much, Ravikiran. I mean, it was really a very exhaustive look at the in-hospital management. And I think, like I said in the beginning, we keep learning every day. I think all the various options and combinations you gave, I think we all know that it varies and we're all always caught off guard. So it's always a challenge to manage this. I think one of the main things, the changes that has happened, because I remember when I started practicing, we had this, this original trial by Vandenberg had come out, and we were all trying to get the sugars down. And then literally 4 or 5 years later, the next trial came out and said, don't do that, don't do that. And then we went back to doing what we were doing anyway. And I always used to wonder whether the hypoglycemia was, like you said, a mediator or just a marker of a person who's, more sick at baseline. Someone who does not have the, whatever the glycogen reserves, and therefore is unwell, and so is presenting like that, the recurrence. So I saw that you had mentioned in one slide that spontaneous hypoglycemia is a marker of increased mortality. Was there actually a study done where they compared insulin-induced hypo versus spontaneous hypo? I was just curious. I've not actually come across a study like that. So did they do that?
Small study only. Small studies were done.
Okay.
From the same institution, they took two set of data, and predominantly from medical ICU, and
Okay.
small study, single institution study.
It would make sense. I mean, I think it's common. So I now throw it open for discussion. Any comments, any questions? I think you mentioned correction factor. There is one comment in the box about what the correction factor is, Ravikiran. Did you just want to explain it?
Yeah, I think already the one doctor has already given the explanation.
Yeah.
So it is the putative blood glucose reduction that could be achieved with 1 unit of insulin. So there are the formulas use either 1500 as denominator or 1800 as denominator to arrive at correction factor. I think the doctor has already mentioned he has explained it simply.
Do you actually use it? I hardly ever use it.
No, I feel it's more academic. In day-to-day practice, I think it's we don't indulge in such complex calculations.
Exactly.
Ravi Shankar, you are the one who were very keen to have this topic done. You have any comments?
Sure, yeah. So typically when we are treating patients at home with type 1 diabetes is very...
Your voice is not clear, Ravi. The voice is not clear.
Can you hear me better? Can you hear me better now?
Yes.
Without a mask, Ravi.
Yeah, sorry. Yeah, sorry. Let me try this. No, I was saying that we do use the correction factors and carb coverage when we're calculating bolus doses for patients with type 1 diabetes. typically, when they're at home. Doing it in hospital, as Dr. Ravikiran mentioned, is not that usual. So going back to what Vidya said about my suggestion to have this topic was that unfortunately most hospitals and inpatients do not have the privilege of having Dr. Ravikiran or someone like him manage their blood glucoses at home. Sorry, during their hospital stay. So I've been privy to some in-hospital glucose management for a few patients, one with, a gangrene of their foot, where it was really bad. I mean, their average blood glucoses were running in the 200s to 250s. And that was what prompted me to ask for this topic to be discussed. What I'm hoping will happen is that more people will start consulting endocrinologists and diabetologists to manage hyperglycemia. It is an art, and I think the more experienced the person is in doing it, the better the outcome.
Would either of you want to respond to that?
I mean, I totally agree with, it is an art. Like I said, I don't think we have any, and I think it is important to get a diabetologist or an endocrinologist involved. I think I totally agree with that. I think just the sort of the intricacies or the nuances of managing people with diabetes and being able to look at all of the factors that go into play that determines sugar control, I think it is important. I think the problem in India happens that, not a problem, I think it's just one of the many challenges that we face. Not all the hospitals may have access to an endocrinologist, certainly. I think there are very many good physicians also who would do the job, and they do it. Very experienced physicians also take on this role, and they do it. And I know places where predominantly it's a surgical unit, and I'm sure Dr. Vidya, you can chip in. I know a lot of anesthetists who look after the sugars, for example, for those long stints in the theater. They look after it, and then we sort of pick up once the person returns to the post-op ward or the monitoring unit. So, yep, I don't think there is any. I think one significant advance that was made. I mean, like even coming back to your point, Dr. Ravishankar, even the ADA, the Endocrine Society, came out with guidelines for management of inpatient hyperglycemia just a few years back. And I think even that sort of understanding that it's such an important topic, and to at least give some broad guidelines, and this thing itself took some time in coming. So we've had that now for the last, I believe, at least 5 to 7 years. And I don't know if it has impacted significantly on improving sugar control while in the hospital, but at least there is some sort of a paper or a guideline available that we can sometimes use.
I'd like to add something about the sensitivity, the insulin sensitivity. In my practice for type 1 diabetics, we always taught all the children about how to calculate. And it's a simple calculation of 100 divided by the total daily dose. And then the child, kids who are older, they can actually easily do the correction factor, and it leads to a better management. So I would sincerely suggest that everybody who is taking care of type 1 diabetics to actually proactively teach every child how to do the insulin, how to understand insulin sensitivity and do the correction factor, because it really helps the children in their management, and especially when they kind of lapse out of their regimens and they eat more or something, and they know that there is a correction factor, they get back on track. Thank you.
Right. Sorry, the formula that you just said is using glucose and millimoles per liter. So for people in the United States and India, it's a milligram.
It's in milligrams, right? I'm sorry, because I knew about that formula, which I practice in. Yes, I know. I was talking about millimoles. I was talking
right.
about
So 1800 is probably better. Yeah.
Yeah, 1800 in India. Right. Thank you. Thank you for correcting me. Thank you.
Dr. Srividya, you have your hand up. Would you like to say something?
Hi, good evening, Ravi. Very, very well put together discussion. And thanks, Jayashree, for vouching for good physicians. I was actually going to object saying, hey, you've forgotten the physicians, but thank you. But having said that, I think one of the biggest lessons of the last 2 decades of practice was one of the biggest difficulty was moving away from the so-called sliding scale regimen which we were using. One of the most, how to say, dangerous regimens we were using because it was causing so much of fluctuation in the sugar level. With the basal bolus regimen, I think things are stabilized, and adoption of more and more clinicians into that system is what is stabilizing the whole system. Because like you said, even for physicians to be there everywhere in IP is not happening in many places. To have standardized schedules and making more awareness about in-hospital optimization of insulin itself is a very, very, very big challenge. So I think we are on the right track now, but adoption is still a very big challenge.
Actually, my observation is there's a, unnecessary fear of hypoglycemia, especially in the inpatients. But at the end of the day, inpatients are being watched, and you can always check the blood glucose often. And the frequent refrain is, oh, patient is starving, so doesn't need insulin. I mean, so these are all the challenges that we face, and that's why as soon as Ravi suggested we do this topic, I just kind of jumped in. Radha, you wanted to mention about correction factor on pediatric intra-op. You want to take it now?
Thank you, Vidya. Yes, I do use a correction factor because the insulin sensitivity factor can be very high in pediatric patients. So once I had a pediatric patient whose sensitivity factor was like 60 or something. So I called the endocrinologist, and this was a couple of decades ago when I was like still trying to understand all this. And I called the endocrinologist and PD endocrinologist, and he told me that means that if I gave 1 unit, then the blood sugar is going to drop by that much. And so this kid was a juvenile diabetic, 11-year-old for craniotomy. So I was a little nervous. So I was in constant touch with the PD endocrinologist, and he helped me with management of this patient. And since then, I've understood that the correction factor and the sensitivity factor are really important, especially in type 1 diabetics and in pediatric patients. And correctly said before, I mean, I was in and out of the presentation since I'm still in the operating room. But I agree now that our goal in the operating room now is to keep the sugar between 150 and 180, actually 140 and 180. We try not to drop it too low. And if we only start treatment for it with insulin, either subcutaneous or insulin or IV infusion, if it runs over 180. And we have in our EPIC chart, the electronic health record chart, we have a drop down whenever there is a best practice advisory. So it gives us a note saying that, hey, your blood glucose is high, treatment recommended. So whenever we check the blood gas or blood glucose level or point of care. And then there's a glucose management chart that drops down, and then we look at it. And again, even though it gives us numbers, we still use that as an art, because once we have done one time, then we see how the thing drops, and then how the sugar alters in the next hour. So based on that, we give the insulin, either IV. Usually we run insulin infusion because over 3 hours, and most of my cases run over 3 hours since I do neuro and ortho. So I'm going to digress just one little thing real quick. And now with management of diabetes, now there are new, I don't know if those drugs are available in India yet, the GLP-1 agonists, the semaglutide type drugs. We have different trade names here now. we found we had a lot of case reports with, aspiration. So the American Society of Anesthesiologists last summer came up with this guideline that we should stop the weekly injection a week before the pill over 24 hours to prevent aspiration. So whenever I see any of these patients, I ask, so now my standard question is, are you on blood thinners? Are you on weight loss medications for either weight loss or diabetes? So many people use it for weight loss as well. So many of the med spas are prescribing those. So sometimes patients don't even consider them as regular medications, and they don't mention it to us, just like they don't mention many of the vitamins and supplements. But we specifically ask, and then I ask a lengthy history as to whether they have all these symptoms like nausea, vomiting, bloating, abdominal pain, feeling of fullness, and diarrhea and stuff like that, and then make sure that they are safe and I explain to them about the risk for aspiration and do a random sequence induction. So that's just to digress, but this part of glucose management in the outpatient arena, and so we have to be aware of those new drugs, and also the SGLT2. I always get confused with that acronym. Yeah, SGLT2. That one also, now we realize that there is a risk for lactic acidosis or ketoacidotic.
But not necessarily hyperglycemia. Yes.
Exactly. So we stop those 3 or 4 days before and for surgery, and so all these new guidelines that have come up. Just wanted to mention those, and thank you for this great presentation.
So, Dr. Radha, actually, there is emerging data that GLP-1 receptor analogs don't really lead to excess aspiration or anything. So the more recent data, I think it came up last week.
Okay, that's from the American Gastroenterological Association. I'm going to go with the American Society of Anesthesiologists guidelines, and I'm going to follow that until I see more data. And that's from the GI docs. So I'm going to take it with a pinch of salt. I'm sorry to say that. I'm an anesthesiologist, and I'm going to go with my society's guidelines and my society's recommendations until we see more, studies that are done. And we are actually doing studies in our institution. They're trying to do, point of care gastric ultrasound to see how the gastric emptying in these patients are after stopping. And we still see some patients still have a full stomach even after having stopped these medications for over a week. And I still would consider them, aspiration risk, and I want to be safe for these patients. Patient safety first. Thank you.
Yeah, there's a question about Dr. Muthuja Raman that how do you calculate dose in elderly? Would that be different? Dr. Ravikiran or Dr. Rajeshi, one of you would like to take that?
For elderly patients, the risk of hypoglycemia in general is more. Better to go with a starting insulin dose, taking into account a slightly lesser requirement of insulin. Instead of 0.4 units per kilogram per 24 hours, it's possibly more prudent to start with 0.3 units per kilogram per day and give half of it as basal, and the other half you can distribute as pre-meal bolus. So 0.3 will be a more reasonable dose to start with, 0.3 unit per kilogram per 24 hours.
Dr. Muthuja Raman, I hope that answers your question. You had a long list, Dr. Ravikiran, about the OHAs that you do not want to be used inside the hospital while the patient is hospitalized. So there is a question about newer OHAs. Though we have dealt with some of that, what would be the list of recommendations that you have? What are the drugs you think orally can be used inside the hospital? We are not talking about ICU or immediate post-op. That's a given. Like really sick patient in the ICU and immediate post-surgical, let's leave them out. Then what about the others?
Pioglitazone, acarbose, oglibose, these two, they are not in any case preferred inside hospital, even for medically stable patients who are taking orally, because they are associated with Pioglitazone, for example, can cause fluid retention and can worsen a hidden heart failure, or it can precipitate a frank heart failure in a diabetic person with who has hitherto been unknown to not known to have cardiac issues. So that issue is there with pioglitazone. Voglibose and acarbose, their glycemic efficacy is less. Chance of bloating is more. Already the patient may be taking more number of medicines inside hospital. So the benefit versus risk ratio will be not favoring voglibose or acarbose. These two I will not use in any case within hospital. Gliptins, a lot of studies have been done. Sitagliptin, linagliptin. If the creatinine is more, dose reduction is required for sitagliptin. For linagliptin, dose reduction is not required in adult patients, type 2 DM. Those agents can be confidently used in medical patients who come for other purposes, like who is recovering from MI or who is recovering from a febrile illness, those sort of situations. Those who have predominantly GI presentation, either vomiting or diarrhea, gliptins are known to cause GI side effects. So in this particular subset, gliptins may not be recommended in the first few days till the symptoms subside. What is left is GLP-1 analog. There are emerging data about GLP-1 analog being good agents for even in patients with sepsis, but who don't yet have hypotension, who are showing early signs of sepsis syndrome, or admitted for other reasons, who have a stable hemodynamics. Even GLP-1 injectable analogs, daily injectables have been studied and published. Sulfonylureas, the problem is the available sulfonylureas are long acting. For example, glimepiride works for 24 hours. So once you give, you can't control the dynamics, the kinetics anymore. The patient may go into hypoglycemia in the midnight. And the problem may be, if you want to use a sulfonylurea, your low dose glycoside modified release, which works for around 12 hours, may be a reasonable option if at all we want to use sulfonylurea. So these are the options available in India right now. Dr. Jayashree, you want to add something?
No, I think you covered everything. That's fine.
So there's a question from Dr. Shivapillai. Is the management same for obstetric patients? What about neonatal hypoglycemia risk? I suppose obstetric we'll have to classify as antenatal and perinatal. So maybe you can spend a few minutes on that. We have some time.
So we need to have information about the kind of diet the person is able to take at that point of time. If the patient continues to take the usual food intake and usual nutritional intake is met, we can cut off like metformin 2 days before or 3 days before and rely only on insulin. If surgery is planned or normal delivery is anticipated in the next 18 hours or 24 hours, then better to get admitted and start on simultaneous dextrose plus insulin drip for tighter control without going into hypoglycemia or slipping into hyperglycemia. But again, this is an ideal situation. In an average sort of situation, we may have to decrease the long-acting dose, and depending on the patient's intake, we may have to give more of short-acting every 6th hourly or every 8th hourly. So it requires close coordination between the treating team and the preterm or patient.
Right.
But,
So,
sorry, I just wanted to add for pregnant patients, quite often what happens is that the treating physician may not be necessarily in the hospital where the delivery is taking place. At least that's what happens to me because I look after people who deliver in different places. So I write to the patient, once you get admitted to the hospital for delivery, stop your metformin, because otherwise they continue taking it when they are feeding. Like Ravikiran said, we reduce the dosage. So if they're on a certain dosage of, if they're already on insulin, reduce it by half or 2/3 certainly the night before delivery. Immediately as soon as induction starts, basically the the hormonal dynamics or whatever changes so that their insulin requirement comes way down. As long as they're not a type 1 a person with type 1 diabetes, it's easier to manage. Type 2s are, you give them one shot of the long acting the previous night and they should be okay. Most often they are taken up for their induction. We can just monitor their sugars and use insulin as needed. The type 1s do need to be on a simultaneous insulin infusion along with a dextrose infusion. So that becomes a little bit more challenging.
So maternal insulin, I think Shiva's question was if maternal insulin increases the risk of neonatal hypoglycemia.
Sorry, what was the question? I can't see it also.
Yeah, I think he said, I think his question was about the risk of neonatal hypoglycemia when using insulin in a pregnant woman.
Actually, the idea is to suppress the endogenous insulin by giving exogenous insulin. If it is undercorrected pre-op, the higher ambient glucose will trigger more insulin release from within the patient's body itself. So the endogenous hyperinsulinemia will be there, which may precipitate subsequent complications. So the idea is to give adequate insulin to keep glucose at a normal level between, let us say, 110 and 150. So that the endogenous hyperinsulinemia is kept to a minimum. In type 2 diabetes, I am telling about pregnancy in type 2 diabetes.
Right. So he's asking what happens if you give insulin. I don't know, Shiva can speak for himself, but I interpreted it as whether giving insulin to the mother will lead to hypoglycemia in the baby. And it shouldn't, technically, because it doesn't cross the placenta.
Could both of you hear what he was trying to say? Could either of you? Basically, he was wondering whether the question was whether maternal insulin administration could cause hypoglycemia in the newborn. Which the direct, obviously, direct effect is answer is no, right?
No.
Yeah, it does not cross the placenta.
Yeah. So Aarti has a question about chronic diabetics and metabolic syndrome patients presenting in heart failure, but they are in the ward. Then she wants some tips about blood sugar management for this category of patients. Basically, long-term diabetics presenting with heart failure.
If the person is hemodynamically stable, we can, in addition to other heart failure drugs, if the person has been admitted for medical problem, if there is no worsening renal function, progressively worsening renal function in the recent few days, if there is no vomiting, the patient is continuing to eat, then we can add SGLT2 inhibitor. It has been shown to improve cardiac function and eventually result in better cardiac outcome over next several months. But this subset of patients will be a small fraction. Majority of patients who get admitted with the cardiac failure, generally we don't add SGLT2 inhibitor. We manage with insulin and rely more on fluid control and diuretics. That will be the safer option in the short term. After the patient recovers from that hemodynamically brittle state into a more stable state, if the azotemia is, if that is azotemia, whatever is there, it's not progressing, the renal function is stable, the patient starts taking food again normally in a normal fashion, then maybe third day or fourth day or fifth day, we can consider adding SGLT2 inhibitor for sugar control. So that will be one part of the story. Anything, Dr. Jayashree, you want to add?
Nothing.
I think it's mainly about whether to give SGLT2 inhibitor in the acute setting. It depends on whether the patient is is in a very sick condition, whether the azotemia is progressive because of some other illness. In that case, we will not give SGLT2 inhibitor. And if the patient is already in near shock or kind of evolving hypotension, again, SGLT2 inhibitor should not be given because it may worsen the hemodynamic status. So these three conditions will be contraindications for SGLT2 inhibitor. Once the patient recovers from a frank heart failure or sepsis with heart problem, once he recovers from that, once he has a stable intake, once the renal parameters are stable over a few days, then we can institute ACE inhibitor for improving the long-term cardiac outcome.
Thank you, Dr. Ravikiran. Krish Srikanth, are you free to talk? You put in a long message in the chat box. Maybe you'd like to speak. Krish Srikanth. Right. So Krish Srikanth says, thanks for a wonderful presentation. He has a few points to add that HbA1c measurement is probably for all hospitalized patients. HbA1c measurement may be mandated so that we don't get carried away by that blood sugar that we just check at the point of admission. And if for diabetic patients, it is better to schedule them first thing in the morning and have a follow-up with the diabetologist. And always the dose and use of what type of blood sugar medications as well has to be taken into consideration. Return to regular medication after surgery has to be supervised. Is his point, because many times patients are very regular on medications at home. Once all the OHs are stopped in the hospital for the surgery, sometimes they are not put back on their regular medication. So the point is well taken, Krish Srikanth. And what else do we have? So like
Just one of the exceptions I want to point out to this. The point is extremely relevant and pertinent. In my hospital, I see a lot of chronic renal failure and CLD, liver dysfunction patients who come with hypoalbuminemia. Many of them have falsely low HbA1c. I would rather be forced to rely more on the sugar level on way to judge how much medicine I should give. So this will be some of the exceptions to the general rule that we should go by HbA1c.
Shiva Pillai has another question. What about CGM and then just adjusting, correcting doses of ultra short acting insulins? Many patients are on continuous glucose monitoring now. Would you like to respond to that?
Well, I mean, I think the answer has been given there. In general, in fact, I wanted to ask if anybody is using CGM. In general, we don't use CGM in at least not in the acute care setting. Once they've come to the ward, we can consider using it. But at other places, particularly when they have blood pressure fluctuations or they're on pressors, the usage of the CGM will not give very accurate values. And always the problem with the CGM is it will falsely show a low value, or it may not pick up a hypo when it's strictly necessary. So nurses have to be educated a lot. I don't think we are yet at the point here in India at any way where we can consider using CGM on a routine basis in the hospital. I have used it in people who've been in the hospital for a long time, for various reasons. They are very stable, but for some reason they're not getting discharged. In that situation, we can use it. In other situations, it's still too unreliable to be used for monitoring in the hospital. Are you using it, Ravi?
Shiva Pillai is from South Africa, and perhaps they have started using it more than we do it here. So hence the question, I guess.
Maybe.
And Ravi, all the points that you raised have been also put down on the chat box by Ravi, is that hypos are not very reliably detected, and vascular instability and perfusion abnormalities may make interstitial glucose readings unreliable. So that's something we all need to remember. A lot of people have appreciated your presentation, Dr. Ravi. And Aarti has another question. Is there any correlation between HbA1c values and thalassemia? Do we need to, is there any error because of that?
Except iron deficiency anemia, all anemias show slightly low HbA1c because of rapid turnover of blood. Only in iron deficiency anemia, there will be a 0.5% increase in HbA1c, false increase in HbA1c. That is a main point to be noted here.
In thalassemia, we never use HbA1c ever, because particularly because of their repeated blood transfusions. So we just do a fasting PP to screen for diabetes. they are very prone to particularly secondary diabetes. Yeah, we just use a fasting PP to screen for it.
Right. Thanks.
One roundabout way to sort of get at average value will be adding 2 more values to what we do. We already normally do fasting and post breakfast. The patient can be encouraged to do on post lunch and post dinner also. So we sort of know that all the values are within that normal zone between 140 to 180. So if then we are reassured that the patient is doing well. So we can add 2 more values to the usual glucose, and that I think gives a better indication than HbA1c in these patients.
So Dr. Gayatri is an obstetrician gynecologist, and she has a question. Gayatri, would you like to speak out your question?
I could do that. Thank you. So I was just having this doubt. Why is it that HbA1c is never considered to be a tool to use to check glycemic control in the second and third trimester of pregnancy?
Partly because of the hemodilutional effect that happens in the mid trimester. And partly because HbA1c will not be useful for day-to-day management of glycemia in pregnancy. Because the average glucose correlation will also be altered, may also be altered during the hemodynamic changes, the dilutional changes. And most of the international bodies don't recommend HbA1c as a guide for choosing treatment. So HbA1c could give us a general idea where the patient is, but it is not useful for altering the insulin dose or instituting insulin dose in the middle of pregnancy. It's more for general interest that HbA1c is seen. It is not useful for daily treatment in pregnancy.
Thank you. So I think it's also due to hypoalbuminemia, which most pregnant women have. Just like CLD, how HbA1c is not an accurate marker, I think probably that also contributes.
Possible dilutional effect, possible hemodilutional effect.
Yeah. Thank you. Thank you.
Thank you, ma'am.
We have Dr. Vidya, intensivist, also logged in, and of course, many of the studies Dr. Ravikiran quoted were done in ICUs. Though the majority of people attending the session or maximum amount of in-hospital glycemic control probably happens outside the ICU. Dr. Vidya, you have something to add?
Well, I think it was a wonderful presentation, well covered and good moderation as well. So nothing major to add, except that, yeah, Vandenberg study did come and it was predominantly in the surgical ICU. So we tried extrapolating. And I think we realized that, yes, sugar control is necessary, but hypoglycemia is worse as it is in other settings as well. So we have to guard. And the nice sugar study between 144 and 180 is what we target. And just one point that I feel is that in ICU, sometimes instead of using the regular insulin as an IV infusion, sometimes they go for these aspart and lispros and all of it. And I think there's just no difference between using a regular insulin versus this when they're using as an infusion. And for that reason, and for cost reasons as well, I think we should go with the traditional Act Rapid. I mean, I'm just using that because that's the commonest thing that is available as a regular. So I mean, that's something that I thought I would want to just stress.
Yeah, thanks.
Agree with your observation. As long as the insulin is given IV, both are equal only. The difference may appear only when transition is done to subcutaneous insulin. Again, that benefit may be apparent only in a select subset of patients. Most of the patients continue to do well on subcutaneous regular insulin, human insulin.
Right. There is a question in the chat box. How often should potassium be checked during insulin infusion in ICU patients?
On the first day, maybe once or twice, especially if the person has come with hyperglycemic crisis. But if the person has not come with hyperglycemic crisis, then the chance of precipitating a hypokalemia is remote. If there is other medical condition going on, like some GI loss or azotemia, then those conditions may make it important to check potassium daily. Otherwise, insulin infusion alone will not push the person into hypokalemia after the first day. There will be a kind of homeostasis achieved after the first day. So hypokalemia happening solely because of insulin infusion after the first day is unusual. If there are other comorbid conditions, we can continue to check daily.
Thank you. You already covered this, but would you like to just quickly do a recap on what are the OHAs that should be stopped before surgery and when? So there is a couple of questions on that in the chat.
Pioglitazone and acarbose, oglibose. Acarbose, oglibose are not particularly useful in terms of HbA1c reduction, and they also cause bloating. So prior to a surgery or prior to a major hospital admission, we can stop that. Pioglitazone definitely should be stopped. Metformin we can continue till 24 hours before surgery. If it is a daycare surgery, even 12 hours before surgery, we can still take metformin. Sulfonylurea, there are 2 or 3 types of sulfonylureas commonly in use in India. One is Amaryl or the Glimepiride. It is a long-acting one, 24 hours acting. Better to stop 24 hours before so that surprise hypoglycemia does not happen on table. Glycoside is a relatively short-acting drug, 8 to 12 hours action. Till the previous morning, we can still continue to take glycoside. On the night just before surgery, possibly we can reduce the glycoside dose to half so that the hypoglycemic effect does not extend into the duration of surgery after the overnight fast, after the last meal, 9 o'clock or 10 o'clock in the night. So glycoside being a short-acting drug is unlikely to cause a long-lasting hypoglycemia extending on to the next day. So we can continue till the evening before surgery, but take half the dose the evening before surgery. Another sulfonylurea is glycinase or glipizide. Similar effect. We can definitely continue till the morning, 24 hours before surgery. The dose in the previous evening, again, better to reduce by half. So these 3 are the common sulfonylureas we see. Glibenclamide, better to stop 24 hours or even 48 hours before. It's very hypoglycemia prone. The most hypoglycemia prone among the 4 sulfonylureas available in India. So I think these are the 4 common oral drugs. Now Ribelsis is available. It is a GLP-1 analog, oral GLP-1 analog. That shouldn't cause any hypoglycemia. We can continue to take till the evening prior to surgery.
Yeah. So just a bit of a digression. So these are for traditionally when patients used to fast for longer, and most of the major surgeries were done under general anesthesia and all. So now the trend has moved completely. We have reduced fasting times. We allow maybe solids. We obviously stop 6 to 8 hours before, especially in diabetics. But we are giving clear liquids up to 2 to 4 hours, and we restart. Many procedures are done under regional, do not involve GI, and patients can pretty much drink or take for at least liquids immediately after coming from the OR, or definitely within 2 hours, and then they are on to their diet. At that time, what we find is, because traditionally we tend to stop all these medications from the previous night or sometimes 24 hours, we are landing up with hyperglycemia and forced to use insulin in insulin naive patients. Then then everyone is hesitant, and then unnecessarily the blood sugar goes above 200 or whatever. And then, so do you think we need to rethink this whole thing, given that the fasting protocols and early enteral feeding protocols have been put in place now?
If it is going to be a relatively short duration surgery lasting not more than 2 hours, and the patient is allowed some sort of intake, a minor snack on the morning of surgery, then the treatment also can be decreased proportionately and not stopped altogether. Suppose a person is on a combination of gliptin plus metformin, which is very common nowadays. The gliptin alone can be given on the morning of surgery, where a snack is allowed. That should not cause hypoglycemia during surgery done in the afternoon or evening. So gliptin alone is okay on the morning of surgery, provided the patient is allowed some snack to be snack on the morning of surgery. Suppose the person is on insulin. If it is a premix insulin, the night before surgery, the person can take 80% of the premix insulin dose. And on the morning of surgery, again, as you told, if the person is going to be allowed a small snack, then the premix insulin dose can be decreased proportionately. Maybe 40% or 50% of the usual morning dose can be still be allowed on the morning of surgery when a snack is given. And long-acting insulin, since long-acting insulin is going to be given once a day mostly, the previous evening, suppose if you are going to give Glargine, Lantus or Besaglar, the previous evening dose of long-acting insulin can be reduced to 70% or 80% of the usual dose. So these are the common changes made in the common medications. Gliptin, we can go ahead without metformin, but for other insulins, we have to proportionately decrease the dose.
Yeah. Thank you very much for that clarification. Dr. Manoharsha is a young surgeon. You have turned your camera on. Manoharsha, you wanted to ask something or say something?
Good evening. Good evening, everybody. Thank you for this beautiful session. Today I have learned that diet control can be more harmful to the post-surgical patients. So I'm saying the data that Sir has shared. So, which is the safest insulin for post-surgical patients? Right? I think I must have missed that part. You must have discussed. Can you just reiterate on that?
So Manoharsha wants to know what is the safest type of insulin to be used in the perioperative period for surgical patients. Yeah.
There are two situations. One is the person is kept totally nil per oral. If sugar is higher than 180, then we can start basal insulin. 0.2 units per kilogram per day we can give. And on top of it, we keep checking sugar. If it crosses 180, you can add a correctional insulin at 6-hourly intervals. So that is one way. Or if the person is allowed food daily after surgery, then we can give basal bolus insulin as we discussed. One basal insulin and the bolus insulin pre-meal 3 times or 4 times as per the diet regimen.
Oh, thank you.
Was the answer appropriate? I am not sure I heard the question correctly.
Yes, sir. The same thing. The type of insulin, like among the long-acting, short-acting, rapid-acting.
Which type of insulin to use in the perioperative? That was his question.
Okay. Yeah. Okay. I think okay.
Yeah. So if anyone has any questions or comments, please go ahead and raise your hand or put on your camera. Meanwhile, Radhakrishna, your take on today's session.
No, it's lovely listening to Ravikiran. We've been associated for over 10 years. We worked side by side, and all our patients have taken very good care of us. Diabetes concerned. Actually, I myself, and he's my personal physician, and one of the best physicians I've ever seen. Having said that, of course, diabetes is a bit of a Greek and Latin to we surgeons. I don't hesitate to order for 10 milligram Lasix or 100 milligram hydrocortisone, but insulin, no. I don't do that because, there are specialists, and of course, there are specialists like Ravikiran, taking care of patients. So it's their domain, and the diabetology and insulinology has developed so much. It's very, very difficult for us surgeons to understand the intricacies, and I think I shouldn't strain my ears so much to do that. And then I have one or two questions. So question one is, now we are into eras, early recovery after surgery, in which, we cut down the fasting time, and we also give carbohydrate overload prior to surgery. But we understand that in diabetics, this is contraindicated, that you shouldn't give a carbohydrate overload before taking up for any major abdominal surgery. Ravikiran, your thought on that?
Yeah, he means the carbohydrate preload. And actually, there are studies showing that it can be used in diabetics, but I'll let the expert answer. Dr. Ravikiran.
Yeah, we can manage it either way. If the person takes carbohydrate preload, if we are going to monitor the sugar and add correctional insulin accordingly, I think the diet just prior to surgery doesn't matter much. We are going to keep checking the sugar, and we can modify the insulin regime. What happens with carbohydrate loading? I'm not very familiar with that term. What exactly we give?
This is Vidya has got better idea, but this is actually to avoid any fluctuation blood sugar levels in the perioperative period. So the patient, it's like fasting during surgery. If you overload with or preload with carbohydrate, the sugar levels are maintained. There'll not be a fluctuation in insulin levels as well as glucose levels. The patient comes out of surgery, fresh and untired. Vidya, am I right?
No, it's not for blood. It's not actually used for blood sugar control per se. It's just for enhanced recovery. It is avoiding prolonged fasting and giving complex carbohydrates is. Sorry. I'm forgetting the exact name of the product. Let me just check it for you.
Carboload.
It is called. No, not the trade name. I'm trying to get the actual maltodextrin. Yeah, there you go, maltodextrin. So maltodextrin is used in originally it was started only for GI surgeries where patients are usually not given a meal for major colon and other GI procedures. It was started, but now we have extended it and we are using it even in other cardiac and other situations. But we do come across this problem of the blood sugar going off chart when we are using it for diabetics, because the recommended dose is almost 600 to 800 ml the night before, and again almost 400 ml in the morning. So, Radhakrishna was just trying to ask you about that.
My second question, Ravikiran, is that, why is it that when we have a monitor on the wall showing ECG and blood pressures, why can't we have a continuous sugar monitoring in some digital way there, and, also a insulin dosage injected accordingly based on that? Why we have a CGM, but why don't you have a continuous sugar monitoring on a screen?
I think it is already implemented in few centers across US and Europe. There are several papers on closed loop insulin, glucose and insulin combination in post-op condition in hospitalized patients in US. But I think the technology is not perfected yet to be left to automation. There are several problems with the indwelling catheter. There may arise several problems with delivery. So it's a complicated setup. The more the complexity, more the chances of errors. I think that is the main issue. And most of the ICUs anyway have a dedicated nurse, one nurse per bed or one nurse per 2 beds. So manual input is not an issue in ICU and in post-op wards also. I'm not sure whether to go for automation and face unforeseen errors in the machinery, or better to just depend on human labor and do things manually and at least avoid machine-related errors. I'm not sure which one is better, but already few centers in US and Europe have implemented closed-loop systems, CGMS readings showing on monitor. All this, it's simply a matter of technology. Whatever is seen on the device, it just has to be transmitted to the bigger monitor. So that shouldn't be a big issue. I think in ICU and post-op wards, already there are enough personnel. We can just take their help instead of allowing machines to take over and one more set of errors appearing through the machines. That is just my thought. I'm not sure how others feel. Where people are not there to do the job, probably we can depend on machine. But I think our ICU is a 1:1 ratio. They are already there to look after certain things. I think that will reduce the errors, I think.
Dr. Jashi, what is your take on that?
I think, like I mentioned earlier, the main problem is going to be the accuracy of the systems of the continuous glucose monitors we have right now. Most often we use and the place where it is measured, the interstitial fluid, it's to do with the quantum of the blood flow and the you know the what do you call that, the fluid dynamics of the blood flow to that area is very variable. For example, even when we use CGM in the outpatient setting, quite often people will come in and through the night we'll see a very low value. It is just because in the night, when they're just lying down there is not any blood flow to that area. So you need that blood flow to go and the glucose to get this thing. So they'll think they're having a hypo. So I'm saying I don't think it's accurate enough right now to replace either checking the blood sugar. I think quite often in the operating theater, it happens with a blood gas. You most often have an art line, so you check it through that, or just pricking the finger and checking the sugar. It's not a substitute for that as yet.
Yeah.
Already few things are available, like called gluco commander. It is available for ward use, especially while transitioning from ICU. Basal bolus regimen is used. The gluco commander already is in place in many centers. I have seen few papers coming from some of the centers. I think it is close to what Dr. Patta refers to.
I'm sure there's a
Doc-
lot of apps on mobile for insulin correction, which you can safely use.
Definitely, there are computer-based algorithms which possibly manage better than human brain, where the doctor has to stand and calculate and every time give a fresh input. The computer-based algorithms are probably more accurate. How to bring all these elements together will be a challenge. So,
Can
in
you
some
name
areas,
some
the
apps
computer
which we can use?
Yes, apps are there. I am unable to recollect one by name. I will just check and message you, sir.
Right.
But apps are there. Using the artificial intelligence and machinery is beneficial in certain areas, like for calculation, computing, but not so accurate in other areas, like involving or developing a closed loop system where the errors can be amplified either at this end or that end. The sensor could be defective or the insulin delivery could be defective. Things could go wrong at many places. So the errors could be amplified. So in certain areas, artificial intelligence and computing is better than what we can do. In certain areas, the errors are more while involving machinery and automated systems. So bringing all the elements together and still ensuring less errors will be an issue.
Dr. Srividya, you have a hand up. You want to say something?
Yes, I wanted to ask Ravikiran, this Ribelsis, since we generally use it on empty stomach, can we continue to use it on the day of surgery also, since it does not cause hypoglycemia? But there are some studies which say it is causing gastroparesis, and how does that work?
If it is a short-term procedure, not lasting more than 1.5 hours, and the surgeon is planning to put the patient back on a regular diet the same evening, sort of a daycare procedure, and if the patient is already adapted to Ribelsis in the previous few months, not experiencing any major GA issue with Ribelsis, then I will be happy to go ahead with Ribelsis on morning of surgery also. Only thing, we have to time it appropriately. After Ribelsis, we are instructed to drink just half a glass of water and leave the stomach completely empty for 1 hour for ensuring good absorption. That is the only guideline to be followed. Otherwise, I think if a patient is already doing well without any GI symptoms on Ribelsis, for a daycare surgery, where the surgery is slated in the late afternoon, where a morning snack is allowed, we can still give Ribelsis.
Thank you. And Dr. Radhakrishnan, this very interesting concept of carbohydrate loading, which you were mentioning, this concept came from athletes where prior to any high intensity workout or major Olympic events, there was this concept of doing a carbohydrate loading before they go on the event to ensure sustained energy levels. what is happening with maltodextrin is that post-surgery, we are seeing a lot of surgical site suture infections because of persistent high sugar, which we are struggling to bring down. Because the requirement of insulin post-surgery in patients where we have done carbohydrate loading is very, very high. This is something which I've seen with a couple of ortho spinal surgery patients where they were given maltodextrin, non-diabetic also. The second thing is that I think the essential thing about post-surgical insulin requirement also depends upon how the patient's sugar control was prior to surgery. And that is one of the most crucial thing. If the person's sugar control is good, and if it is an elective surgery, the sugar control is not good, then we might as well do a good diabetes control, bring the glycemia into control before we take up the person for the surgery. But if it is an emergency surgery, we have no choice. I think it's all about just stopping the OHAs and going on a full load of insulin and then ensuring a better outcome. What do you say, Jayashree and Ravikiran? I mean, this is something which I've been practicing for quite some time, and I've not regretted doing it.
Yeah, Srividya. I mean, I'm not at all familiar with this concept of carb loading, so I really can't answer. This is
no, carb loading is not something which we should ever agree to as physicians. But I'm talking about the insulin requirement, because I have seen in a couple of this was done in cancer hospitals and all, where the surgery is prolonged and they have loaded the patient with, because they are NPO for a very, very long time. Couple of times this is what I had seen, and then we have to go very strong and say, please don't do it, don't use maltodextrin. We will ensure the patient's nutrition through Ryle's tube later, post-surgical, things like that and all. And over a period of time, things have changed. But the surgical outcome and the post-surgical infections were very, very high with some of these patients.
Yeah, I mean, there is a body of evidence to the other side as well. So I again, given that many of these things are pharma driven, so there is a chance of bias in the study design or whatever. But for at least for GI surgery, there is a reasonable good body of evidence that carbohydrate preloading helps. But then that is mistaken by others as trying to give dextrose or something, or infusion of IV dextrose or 10% dextrose. That's not it is. So oral maltodextrin, and definitely I agree with Srividya, but in diabetes we do face a challenge, so we just dial it down, like we give half of what we would normally give to non-diabetics. And definitely if the blood sugar control is not good in the preoperative period, then we skip that, because managing the blood sugar becomes more of a challenge. So that's what we do. There is a last one, since the person has taken the time to type a long question. I have the basic doubt: when endogenous insulin resistance is the crux of diabetes, how can we explain effective response to exogenous insulin? How are they different? How can insulin sensitizers increase the efficacy of endogenous insulin? Please pardon me for the silly question. It's that's a message typed by Dr. Radha, I guess.
Dr. Radha, I would say it's not at all a silly question. You've attacked the very crux of diabetology, and I'll let Ravikiran answer it.
See, the main difference in exogenous versus endogenous insulin is endogenously it is delivered directly through the celiac axis into the liver. Liver is a major site of metabolism of glucose processing, either into glycogen or glucose production from other sources. So the endogenous insulin directly from pancreas through the celiac axis goes to liver, but not so with exogenous insulin. Exogenous insulin, half of it gets wasted in the systemic circulation. Wasted may not be the right term, but rather distributed in the systemic circulation, and it reaches targets which were not intended initially. So, but the problem is the beta cell has a certain limit how much it can secrete at a given time after so many years of diabetes. Initially, beta cell hypertrophy will be there. that will compensate for insulin resistance. After 5 years, 8 years, 10 years, slowly the beta cell function also will decline, the number also will decline. A UKPDS study showed that even at onset of diabetes, around 50% of beta cells number declines and 80% of function declines to for the patient to manifest as DM. So that situation worsens further down the road. So there is a limit to how much the pancreas, how much insulin the pancreas can produce to counter endogenous insulin resistance. Probably after 10 years, pancreas will be producing close to 30 units per day or 40 units per day, which may not be enough to control glucose in that particular patient. Exogenous insulin, there is no limit. We can give as much as we need to control sugar in a given patient. So that is the only advantage of exogenous insulin. And how can insulin synthesis increase the efficacy of endogenous insulin? I think that's a basic fact which we make use of in the initial few years of diabetes. In the initial few years, the resistance, once it reaches a peak, it remains more or less stable at that level. Only the beta cell function slowly keeps drifting down. So in the initial few years, we can manage very well with either pioglitazone or metformin or both. ADOPT trial showed that fact only. It was a trial lasting around 5 years. They compared the 3 arms. One arm had sulfonylurea, which secretes, which makes the beta cell release insulin. Another arm had pioglitazone, another arm had metformin. Those who were on metformin and pioglitazone, they performed very well. Those who were on sulfonylurea, which makes the beta cell release insulin, it performed very well in the first year. Then the beta cells started tiring out, getting exhausted after 1.5 years. By the end of 4th year, the sulfonylurea arm performed worse than metformin and the pioglitazone arm. That means the insulin secretagogue arm performed worse than insulin sensitizer arm in this ADOPT trial. So that is a proof for this concept that initial few years we can very well manage with the diet, exercise, and insulin sensitizer alone, utilizing the endogenous insulin to work. After 5 years or 8 years, when the beta cell output declines, we may have to introduce exogenous insulin. Thank you.
I hope that answers your question, Dr. Radha, and thank you for raising a very important point, which I'm sure everybody needed clarification on that. We actually overshot time by 10 minutes. I'd like to thank Dr. Ravikiran for an excellent presentation and also patiently answering all kinds of questions that were put to him. Thank you, Dr. Jayashree, for moderating the session and giving your inputs. Thank you, everyone who joined in. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.